Welcome to our lecture on the principles of emergency care. In this session, we'll walk through the foundations of emergency nursing, from triage and initial assessment to airway management, bleeding control, wound care, and trauma response. These principles form the backbone of safe and effective practice in emergency settings. Emergency care begins with triage. The word comes from the French term trier, meaning to sort. In the emergency department, triage means sorting patients by the severity of their condition and how urgently they need treatment. Traditionally, triage was a 3-level system: emergent, urgent, and non-urgent. That approach worked, but as emergency departments grew busier, it became clear that more precision was needed. Most hospitals now use 5-level systems, such as the Emergency Severity Index in the United States or the Canadian Triage and Acuity Scale. These tools don't just look at how sick a patient appears, they also consider what resources will be needed. The Canadian system even sets clear timeframes for reassessment, from continuous monitoring for the most critical patients down to every 2 hours for the lowest acuity patients. This structure keeps patients from being forgotten in crowded waiting rooms. Modern triage also includes models like triage bypass, where certain EMS patients go straight to a treatment area, and team triage, sometimes called provider in triage, where a nurse practitioner or physician assistant is stationed at the front to order tests and begin treatment early. Both approaches help reduce delays and improve patient flow. The triage nurse's role is pivotal. This nurse collects vital signs, medical history, and allergies, and screens for safety issues such as intimate partner violence. Depending on the facility, the nurse may also start standing protocols like X-rays, lab work, or pain management. Just as important, the triage nurse must keep eyes on the waiting room, reassessing patients frequently because conditions can change quickly. It's worth remembering that routine triage and disaster triage are not the same. In a normal emergency department, the sickest patients are treated first. In a disaster or mass casualty situation, the priority shifts towards saving the greatest number of people with the resources available. The COVID-19 pandemic brought new challenges. Universal masking, physical distancing, and symptom screening became routine. Many hospitals added pre-arrival questions about fever, cough, shortness of breath, fatigue, sore throat, or loss of smell. Exposure history and recent travel became part of triage. Patients with concerning symptoms or exposures were separated from those without to keep waiting areas safer. The pandemic showed how quickly emergency care has to adapt when a public health crisis arises. Once a patient is triaged, attention turns to stabilization and intervention. Emergency teams use a systematic approach called the primary and secondary survey. The primary survey follows the ABCDE framework: airway, breathing, circulation, disability, and exposure. This means first making sure the airway is open, especially protecting the cervical spine if trauma is suspected. Next comes breathing, ensuring oxygen is moving effectively. Circulation is assessed by checking perfusion, controlling bleeding, and establishing IV access. Disability is a quick neurological assessment using either the Glasgow Coma Scale or a simple AVPU check. Is the patient alert, responsive to verbal or pain, or unresponsive? Finally, exposure means removing clothing to look for hidden injuries while also working to prevent hypothermia. The secondary survey is more detailed. It includes a full head-to-toe exam, history, vital signs, diagnostics, and wound care or splinting as needed. Pain management is addressed as early as possible, usually with rapid-acting medications. If the patient needs a procedure, moderate sedation may be given so the patient is comfortable but still responsive enough for ongoing assessment. Emergency care also includes family support. A crisis can overwhelm loved ones, so chaplains, social workers, and crisis teams are often called in. Families need information, reassurance, and sometimes simply someone to stand with them in a frightening moment. Airway obstruction is one of the most immediate threats in emergency care. It can be caused by aspiration, anaphylaxis, trauma, burns, or swelling such as angioedema. Patients may show choking, stridor, use of accessory muscles, or eventually cyanosis and loss of consciousness. In older adults, risks are higher due to medications, neurologic disease, or dementia. If a patient can cough forcefully, we encourage them to continue. If their cough weakens or they develop stridor and cyanosis, it is treated as a complete obstruction. Once the obstruction is cleared, providers must be ready to begin rescue breathing or CPR if necessary. When basic repositioning doesn't work, artificial airways are needed. An oropharyngeal airway can keep the tongue from blocking the airway in an unconscious patient. A nasopharyngeal airway can be used in semi-conscious patients, but not in those with facial or skull trauma. Endotracheal intubation is the gold standard, often done with rapid sequence medications, a sedative, an analgesic, and a paralytic. Field devices like a king tube or laryngeal mask airway can be placed quickly if intubation isn't immediately available. In extreme cases, a cricothyroidotomy provides a surgical airway. Ventilation is confirmed by breath sounds, oxygen saturation, and capnography, while providers stay alert for complications such as pneumothorax that may require chest tubes. Hemorrhage is another emergency that demands immediate action. Patients can bleed externally or into hidden spaces such as the pelvis, chest, abdomen, or thighs. The signs of shock are cool, clammy skin, dropping blood pressure, rising heart rate, delayed capillary refill, and low urine output. Management starts with 2 large-bore IVs, ideally placed in uninjured limbs. Isotonic crystalloids like normal saline or lactated ringers are given, though lactated ringers is often preferred to reduce the risk of worsening acidosis. Blood warmers prevent hypothermia during transfusion. External bleeding is controlled with direct pressure, elevation, immobilization, and tourniquets when necessary. Internal bleeding is suspected when shock is present without visible blood loss and may require rapid transfusion, imaging, or surgery. Wound management is another critical skill. Wounds can be abrasions, lacerations, contusions, hematomas, avulsions, or penetrating injuries like stab wounds. Documentation is key, especially in cases of intimate partner violence or forensic trauma. Cleansing is usually done with normal saline, while antiseptics like povidone iodine are reserved for initial surface cleaning. Devitalized tissue may require debridement, and irrigation with sterile saline helps reduce contamination. Clean wounds can be closed immediately with sutures, staples, or glue, while contaminated wounds may need delayed closure. Tetanus prophylaxis is provided if indicated, and patients are taught to watch for infection signs such as pain, fever, swelling, odor, or drainage. Trauma as a whole remains a major cause of death and disability. It is the 4th leading cause of death overall in the United States and the leading cause of death in children and adults under 44. Rates are rising in older adults as well. Substance use disorder is often a contributing factor in both blunt and penetrating trauma. When trauma involves more than one body system, we call it multiple trauma. This means a single catastrophic event has caused life-threatening injuries to at least 2 organs or systems. Mortality depends on the severity of each injury, the number of systems involved, and their combined effects. After major trauma, the body becomes hypermetabolic and severely stressed. A dangerous cycle called the triad of death may develop: hypothermia, acidosis, and coagulopathy. Each of these conditions worsens the others, and together they increase mortality risks significantly. Assessment of trauma patients can be misleading. Sometimes the most obvious injury is not the most lethal. For example, a pelvic fracture that isn't seen right away on X-ray may cause massive internal bleeding, while a dramatic arm amputation may have already stopped bleeding due to vasoconstriction. For safety, trauma patients are always assumed to have a spinal injury until proven otherwise. Management of multiple trauma begins with the basics: airway, breathing, and circulation. These life-saving steps are often performed simultaneously by the trauma team. Once the patient is stabilized, clothing is removed for rapid assessment, and a quiet, orderly handoff from EMS to the ED team ensures critical details are not missed. Most trauma centers use a trauma alert system to mobilize resources. The team may include a trauma surgeon, trauma nurse, X-ray technician, nursing assistant, and sometimes an advanced practice nurse or chaplain. The trauma nurse's responsibilities are broad: maintaining airway and IV access, administering medications, collecting specimens, monitoring vital signs, and documenting everything in real time. Preventing hypothermia is especially important. Many trauma bays keep the ambient temperature higher than usual, wet clothing is removed, warm blankets are applied, and IV fluids are warmed. Fluid resuscitation often starts with lactated ringers, but all fluids are used judiciously to avoid diluting clotting factors. Blood products are frequently required. Continuous monitoring of the patient's hemodynamics and temperature helps reduce the risk of the deadly triad taking hold. In summary, the principles of emergency care revolve around rapid assessment, prioritization, and intervention. From triage at the front door to airway control, bleeding management, wound care, and trauma stabilization, emergency nursing is about saving lives under pressure. Mastering these fundamentals prepares you to provide safe, effective, and compassionate care in the most critical moments.